Okay, so we're on part 2 of pharmacology of infectious disease, part 2 of 2. This will cover fungal, parasitic, mycobacterial, anti-helminthic, and vaccines. So looking at our objectives, we'll start out by differentiating how the drugs work, their mechanism of action, how they're given, the important therapeutic uses, and then we'll point out the big and adverse side effects that we want to watch out for clinically. Next, we'll talk about how vaccines trigger the immune system and how that translates to real protection. And then we'll walk through and recognize the right drug for the right bug, when not to give a drug, which is just as important, looking at contraindications, resistance patterns, organ dysfunction. And as always, we will touch on patient education because a good treatment plan only works if the patient understands how to stick with it. And again, our medications that are going to be covered are the antifungal list here, the antiprotozoal, the antimalarials, the antimycobacterials, and then another subcategory of antimycobacterials, and we'll talk about vaccines. Okay, so jumping in with antifungals. So let's start by laying the groundwork for antifungals. Fungi are eukaryotic organisms like us, which means they are structurally more complex than bacteria. That similarity actually makes them harder to target with drugs and also explains why antifungals tend to come with more toxicity. So one key difference is that fungal cell membranes contain ergosterol, not cholesterol like humans, and that's what most antifungal drugs aim at. Their cell wall also contains beta glycans and chitin, which we don't have in human cells, so those become unique targets too. Mechanically, we group antifungals into a few main categories. First, you've got your membrane disruptors like Amphotericin B, effective but known for toxicity, and then your drugs that inhibit ergosterol synthesis, which we have already discussed this mechanism in ClinMed. Those are your Azoles and Terbinafine, which are more common in outpatient settings. Your this is a tough one. Echinocandins, which inhibit the cell wall, are mostly hospital use, not a big focus of the week, but we will reference them. And then lastly is Griseofulvin, which inhibits mitosis, so it works a little differently than the rest. So because fungi resemble human cells, the more a drug hits a shared pathway, the more likely it is to cause side effects. So this we talked about with our selectivity in previous weeks, and that's a big reason why you'll need to monitor liver and kidney function for both of these, any of these antifungal medications. Okay, so starting off with Amphotericin B, affectionately named Amphoterrible, and for good reason. This is a Pauline antifungal that works by binding ergosterol in the fungal cell membrane. That creates pores, which cause the contents of the fungal cell to leak out, kind of like punching holes in a water balloon. So because of this direct kill mechanism, this is considered fungicidal. Clinically, this is your big gun, so think of this for your very severe systemic fungal infections, which is why we have not seen this up to this point in clinical medicine, as we've only talked about dermatologic fungal infections. You'll see it used in things like cryptococcal meningitis, used in combination with flucytosine, in mucormycosis, a rare but deadly mold infection, and Amphotericin B is not used lightly, so it is reserved for severe life-threatening infections because of its significant toxicity, especially to the kidneys. And so this would not be prescribed for our athlete's foot or our vaginal candidiasis. This is reserved for ICU level pathogens. So why is it called Amphoterrible? That is because we have a big issue with nephrotoxicity, which is dose dependent. So the more you give, the more stress you're going to put on the kidneys. The drug also causes electrolyte wasting, especially potassium and magnesium. So patients can get hypokalemia and hypomagnesemia, and that would lead to arrhythmias and muscle issues that will creep in if you're not watching their labs closely. The Amphotericin B actually has quite a few effusion reactions, so fevers, chills, rigors, even like usually with the first dose or two. So patients will feel like they have the flu. This is predictable and patients can be counseled on it, but it can be very dramatic. There's a risk of anemia because amphotericin suppresses erythropoietin production, the hormone that drives red blood cell synthesis, and a risk of renal tubular acidosis, especially with prolonged use. So one strategy we use in clinical practice is switching the lipid formulation. It's less nephrotoxic, but it does come with a higher cost. So you must monitor labs. Think of a BMP, magnesium, phosphorus. Make sure you're hydrating your patients to protect your kidneys. Okay, so let's shift gears and look at a more common and better tolerated class, the azoles. These are pretty much the backbone of the outpatient antifungal therapy. Some of them are fluconazole, itraconazole, voriconazole, posaconazole. So they all have, fluconazole is really the star of the show, but the others are important for broader and more resistant infections. Mechanism-wise, azoles work by blocking the conversion of lanosterol to ergosterol, which is essential for the fungal cell membrane. Specifically, they inhibit enzyme 14-alpha demethylase, and without ergosterol, the membrane becomes unstable. So azoles are generally fungistatic, meaning they stop fungal growth rather than kill outright. So you need a competent immune system to help finish the job. So if you've ever been prescribed diflucan, for example, that is fluconazole, you've used an azole. It's great for things like candidiasis and often would be your go-to for outpatient fungal infections. It's well absorbed orally, good CNS penetration, and so it can be used in fungal meningitis also. Taking a closer look at fluconazole, which is one of the most commonly used azoles in outpatient practice, you'll use this for all kinds of candida infections, oral thrush, esophageal candidiasis, vulvovaginal candidiasis, super common in primary care. So fluconazole also plays a role in step-down therapy for cryptococcal meningitis. So once the patient is stable and transitioning out of the ICU, they would step down from amphotericin, for example, to fluconazole. Now for adverse effects. Hepatotoxicity is rare but possible, especially with long-term courses. That's why we recommend checking LFTs if patients are going to be on this medication for more than a few weeks. Second, this medication has prolonging of the QT interval, so patients with cardiac issues or other QT prolonging medications, you'll want to be cautious. And then fluconazole is a CYP450 inhibitor. We have heard of this many times before, and what we know this means is that it can cause drug interactions. So some of the notable medications are warfarin, anti-epileptic drugs, and statins. So fluconazole overall excellent bioavailability. IV and PO dosing are basically equivalent, and so you can easily transition a patient from inpatient to outpatient without losing efficacy. Okay, next is itraconazole, not quite as commonly used as fluconazole, but still has some key roles. Things like endemic fungal infections like histoplasmosis and blastomycosis. It is also listed as first line for onychomycosis or nail fungus, particularly when, I'm sorry, not for first line, but when terbinafine fails. So this becomes a step-up option in dermatology. Adverse effects, big red flag with the itraconazole is it is a negative inotrope, which means it weakens heart muscle contraction. So it's contraindicated in heart failure. Definitely want to screen for that before prescribing. Like the other azoles, this is also a CYP450 interaction, meaning it can mess with the levels of other medications like statins and anticoagulants. And yes, also hepatotoxicity, so liver functioning is still relevant. Terbinafine, which we saw a lot in ClinMed dermatology. This is used a lot in outpatient dermatology. It works by inhibiting squalene epoxidase, which is an early step in ergosterol synthesis. So that means that it blocks the fungal cell membrane at the front end. And unlike the azoles, this one is actually fungicidal. So the main use for terbinafine is onychomycosis, or nail fungus, also used for tinea capitis and can be used for tinea corporis or curris, depending on whether the infection is widespread or localized. Topical is fine for smaller patches, but for the scalp and nails, oral terbinafine is usually required. For our side effects, hepatotoxicity is a big one. We always want to order baseline LFTs before starting oral terbinafine, especially if it's going to be that longer 6 to 12 week course for onychomycosis. There is a report from some patients that they will have taste disturbances, so weird or unpleasant taste. You may also see rash or GI upset. For nail fungus, this is first line, but if it fails or if the patient has liver issues, you may have to step up to something like itraconazole. Griseofulvin, I would say you can think of this as like the grandparent of the oral antifungals. It works by binding microtubules and inhibiting mitosis, which makes it fungistatic. It slows fungal growth but does not kill the fungus directly. Historically, this was used for dermatophyte infections, especially tinea capitis, but it's used much less today as we have our newer agents like terbinafine and itraconazole that are safer and more effective. Adverse effects include headache, hepatotoxicity, and it is teratogenic, so contraindicated in pregnancy. Also induces that CYP450, which can lower levels of other drugs, something to watch for with things like warfarin and oral contraceptives. Patients should avoid alcohol while taking Griseofulvin because it may cause a disulfiram-like reaction, which is that flushing, vomiting. Generally, they feel miserable. We talked about this in the previous lecture. So Griseofulvin is still on the shelf, but not often first line. Nystatin is a polyene antifungal, just like Amphotericin B, and it works in the same way. It binds ergosterol, forms pores in the fungal membrane, making it fungicidal, but only locally. So Nystatin is used topically, most often for things like intratragus candidiasis, skin folds, diaper rash, or oral pharyngeal candidiasis. So that is your swish and swallow oral preparation for thrush. Side effects, there are not many. It is not absorbed systemically, so that makes it really safe and a good choice for localized infections. The one thing you want to keep in mind is that you would never use Nystatin IV. It is too toxic systemically, so strictly topical or oral suspension where it has that local effect. So you'll see this regularly in outpatient urgent care settings, kids, elderly patients. This is used quite frequently. So when are we using our topical antifungals versus our systemic? Topicals are great for your mild superficial infections, things like tinea corporis, athlete's foot, candidiasis in the skin folds. These infections do not require the deep tissue penetration, and topical meds like clotrimazole or Nystatin will take care of that. So they are safe, cheap, they have minimal side effects. But then if we're treating something that involves hair, nails, deeper tissues like onychomycosis, tinea capitis, or any invasive systemic fungal disease, then you need a systemic agent. So that is where drugs like fluconazole and terbinafine will come in. As we know, our systemic antifungals are going to carry more toxicity, so liver, kidney, QT interval drug interactions. They require monitoring. That means checking labs, reviewing meds, counseling the patient on what to expect. So always match the depth of the infection to the depth of your treatment. If it's just on the skin, start local. If it's deeper, you need to go systemic treatment, but do so thoughtfully. All right, let's highlight some of the antifungal interactions. So the azoles, remember, these are CYP450 inhibitors, which means that they can increase levels of other drugs metabolized by that pathway. So things like warfarin are statin medications, certain anti-epileptics. We want to make sure we're screening the patients for polypharmacy before we start these. Terbinafine also has CYP interaction, but a bit more unpredictable. So sometimes inhibiting, sometimes inducing. So you want to be very cautious in complex patients with long medication list. Amphotericin B, it doesn't mess with CYP enzymes, but it is nephrotoxic, and that risk is additive when combined with other nephrotoxic agents, so things like aminoglycosides. You don't want to double up on these unless you absolutely have to, and you must monitor renal function very closely. Griseofulvin is again a CYP inducer, so that means it can decrease levels of other drugs, including oral contraceptives. That's a classic test question, important for patient counseling, right? We don't want our patient taking something for tinea capitis and getting pregnant. So overview of some of our contraindications. If your patient has liver disease, you're going to avoid your azoles and terbinafine. Both are hepatotoxic. In pregnancy, azoles are a no. They're teratogenic, especially first trimester. Griseofulvin is also teratogenic, so always ask about pregnancy. Document it clearly if you're prescribing these drugs. For heart failure, itraconazole is contraindicated. Again, it is a negative inotrope, so it worsens cardiac function. And in renal failure, we have to be very cautious of Amphotericin B. It is nephrotoxic, so someone with poor kidney function, that can really tip them into acute failure. So some of our monitoring requirements for member Amphotericin B, we have to keep a close eye on our renal function. So a BMP, basic metabolic panel. Don't forget your magnesium, as this drug can waste electrolytes. Fluconazole and itraconazole both require LFTs if prolonged use. So even though these are well tolerated, hepatotoxicity can occur. Terbinafine, we always need to get baseline LFTs before starting oral treatment, especially for those long 6 to 12 week treatments for onychomycosis. Griseofulvin, both LFTs and a CBC, since it can affect liver and bone marrow. So not often used anymore, but if you prescribe it, that's what you're going to be watching out for. So some quick clinical algorithms. Candidiasis, we're going to use either Nystatin, which we talked about in our dermatology lectures, or fluconazole, which we just learned about. Onychomycosis is terbinafine for first line. And then we need the big dog, Amphotericin B, for our systemic fungal infections. Other things like Aspergillus, we'll use voriconazole, which did not cover that in this lecture, but just to mention that. So what are we telling our patients when we're prescribing these antifungals? So our azoles, like itraconazole, need to be taken with food to improve absorption. Griseofulvin, remind patients to avoid alcohol. There is the risk of disulfiram-like reaction, so that vomiting, flushing, always good to bring that up. Terbinafine is one of the biggest counseling challenges because it does require that long-term adherence for nail fungus. So there's a long time, that's a long time for a patient to remember a pill, help them set reminders in calendars or set aside a specific time. And then across the board, because the antifungals have that hepatotoxicity risk, want to make sure you counsel patients to report any darkening of the skin, dark urine, right upper quadrant pain, as those would be red flags that you don't want to miss. So just a summary, ergosterol is the main drug target for antifungals. Polyenes are fungicidal but toxic. Azoles are first line in many of our outpatient infections, as we've already learned. Terbinafine is best for nails. Griseofulvin, older medication, but we still do use that in pediatrics. And kidney and liver function need to be monitored for this drug class. Moving on to our antiprotozoals, our antimalarials, and antimycobacterials. Okay, so antiprotozoals, the major MVP here is metronidazole, one of the most useful drugs that will be in your toolbox as you move into clinical practice. This is unique because it covers both anaerobic bacteria and protozoa. So on the protozoal side, it covers Giardia lamblia, think contaminated water camping tricks, Trichomonas vaginalis, very common cause of vaginitis, Entamoeba histolytica, which causes dysentery, so travel and immigrant populations. It can also be used against C. difficile, so an anaerobic bacterium and major cause of antibiotic-associated diarrhea. Though oral vancomycin is now first line, as we talked about in our last lecture, metronidazole is still in use for mild or recurrent disease. So you will see metronidazole in GI, OB/GYN, infectious disease, urgent care. It will be used across multiple different rotations in your clinical year. So let's look at the very specific mechanism of action of metronidazole. So metronidazole is only activated inside anaerobic organisms. It's reduced or chemically activated in the absence of oxygen, which allows it to form cytotoxic metabolites. Once it is activated, it damages DNA, causing strand breaks, which is why it is lethal to both anaerobic bacteria and protozoa. So it's considered bactericidal and protozoal-cidal. The key clinical point here is because oxygen blocks this activation, aerobic organisms are inherently resistant. So metronidazole does not work for respiratory infections, UTIs that need low oxygen environments to function. So think about body sites where anaerobes thrive. That would be your GI tract, abscesses, pelvic infections, and that is where metronidazole does its best work. So where are we actually using metronidazole in clinical practice? First line for bacterial vaginosis and trichomoniasis. These are both common vaginal infections we will talk more about in gynecology. Trichomonas is sexually transmitted, so we do have to treat partners when we treat that condition. Giardiasis and amoebiasis, both protozoal causes of diarrhea. These are usually travel related or from contaminated water. Metronidazole also used to treat C. difficile. No longer first line, but it is an option for non-severe cases when oral vancomycin is not available. And then intra-abdominal anaerobic infections, often in combination with gram-negative agent like ceftriaxone. So think diverticulitis, abscess, post-surgical infections. So you'll see metronidazole in multiple rotations, OB/GYN, GI, surgery. This one you'll want to know inside and out. So we do have a few notable side effects with metronidazole. Most common complaint is a metallic taste. Patients may say everything tastes like pennies. Along with that, you'll see nausea, GI upset, especially if patients take this on an empty stomach. One big one to always counsel is the disulfiram-like reaction with alcohol. That's flushing, nausea, vomiting, tachycardia. You want to tell patients to avoid alcohol during their treatment course and for at least 48 to 72 hours after treatment is completed. Peripheral neuropathy is rare but can occur if metronidazole is used repeatedly or for a prolonged period of time. And dark urine, this is harmless, but it can freak your patient out. So you do want to let them know. They will see some pigment changes in the urine. Generally well tolerated, but you do have to do some counseling about the alcohol, GI effects, and urine color to keep patients compliant with the medication. And then what are our contraindications? So the most obvious, we just talked about alcohol use. If your patient is not likely to be able to abstain from alcohol, this medication could backfire as they will get that disulfiram-like reaction. First trimester pregnancy, metronidazole has potential teratogenicity, so we avoid it unless there is no better option. It's not absolutely contraindicated, but you would weigh the risk and the benefit. Patients with CNS disease, so there is a seizure risk with metronidazole, particularly patients with epilepsy or history of neurotoxicity, so use caution or avoid if possible. And then hepatic impairment. Since metronidazole is metabolized by the liver, you'll need to adjust the dose accordingly, monitor closely if you use it. So quick review, when we counsel our patients, we're going to tell them they cannot use alcohol during treatment or for 48 to 72 hours after. They may taste a metallic taste while using it. That will resolve. Take it with food to reduce the GI upset. If you're treating trichomonas, vaginal trichomoniasis, you need to treat sexual partners and then advise patients to report any adverse effects, but particularly numbness and tingling. Okay, shifting gears now to antimalarials, which primarily target our Plasmodium species, the parasites that cause malaria. So you may not use these every day in clinical practice, but they are board relevant and they show up in travel medicine or infectious disease consultations. The ones we'll look at are Chloroquine, Mefloquine, and Primaquine. These each have different role in the Plasmodium life cycle. and understanding that will help us explain why each is used. These can be used for treatment and prophylaxis depending on the region of travel and type of plasmodium involved. So we will go into each of these in more depth now. Chloroquine, this was once the go-to drug for malaria and still is used in certain regions, but resistance is now more widespread. So you always need to check the local susceptibility when treating or planning travel prophylaxis. Mechanism of action, chloroquine blocks heme detoxification inside the plasmodium food vacuole. So the parasite feeds on hemoglobin but can't survive the buildup of this free heme, which becomes toxic and it kills it. Effective against sensitive strains of P. falciparum and treats blood stage P. vivax and P. ovale. Adverse effects, generally pretty limited. Pruritus is common, especially in African American patients. This is well documented, worth noting for exams. Rarely you'll see retinopathy with long-term use. GI upset is always possible. So this is less common in US practice, but is still relevant for travel medicine. Mefloquine is often used in chloroquine-resistant P. falciparum and is a good go-to for malaria prophylaxis in travelers, especially to areas like sub-Saharan Africa, Southeast Asia, where resistance is common. Works similarly to chloroquine by disrupting the parasite heme metabolism, leading to toxic heme accumulation and parasite death. You'll want to remember that this has neuropsychiatric side effects. So patients can experience anxiety, vivid dreams, and even psychosis. This can happen just after a few doses. Other side effects, dizziness and arrhythmias, which can make cardiac screening important. Because of some of these effects that we just said, it's contraindicated in patients with seizure disorder or psychiatric illness. So that would include anxiety, PTSD. Before prescribing for travel, you want to make sure to take a good mental health history. And if that's a concern, you would go with a different alternative. Okay, at a different stage of the malarial life cycle, Primaquine is here and it is essential for treating P. vivax and P. ovale because it targets the hypnozoite stage in the liver. So that is the dormant form that can cause relapse. This is the only antimalarial that will clear those liver forms, so it's used to prevent recurrence after blood stage treatment with chloroquine or another agent. Mechanism involves disrupting the mitochondrial function, but the exact mechanism of action is still partially unknown. One thing you will see commonly on boards is Primaquine causes hemolysis in patients with G6PD deficiency. So you must screen for G6PD deficiency before prescribing this medication. Other side effects you'll see are GI upset and methemoglobulinemia, which is a rare blood disorder where hemoglobin becomes more ferrous and reduces the oxygen carrying capacity, which leads to overall hypoxia. Okay, so when choosing our antimalarials, we want to be sure we know our key contraindications. G6PD deficiency, we have to avoid Primaquine. Psychiatric disorders, we have to avoid Mefloquine due to the risk of anxiety, depression, psychosis. Retinal disease, avoid chloroquine. That can cause or worsen retinopathy. And for arrhythmias, we use caution with both Mefloquine and chloroquine as they can affect the cardiac conduction. So important counseling pieces before you want the patient to begin the prophylactic treatment before travel. So some of these drugs need to be started days or even weeks in advance of travel. They're going to continue during and after travel. This depends on the drug, so you would go by the package insert. You're going to emphasize all the things to avoid being exposed to malaria in the first place. So mosquito netting, DEET, long sleeves, bed nets, keeping in mind that medications are not ever 100% effective in preventing malaria. And then you want to counsel them to report any vision changes, of course, any worsening anxiety, especially with those chloroquine and mefloquine. So quick summary slide, chloroquine we can use in the sensitive regions only. Mefloquine can be used in resistant regions, but we have to avoid it in any psych disease. And Primaquine, this is the one we use to prevent the relapse for P. vivax or P. ovale. Okay, moving on to our antimycobacterials. So treating tuberculosis, we have 3 core mycobacterial agents, Isoniazid, INH, Rifampin, and Ethambutol. These are used in combination for active TB, which requires multi-drug therapy to prevent resistance. They are also used for latent TB, often can be used monotherapy or dual regimens depending on the case. So starting with isoniazid, it works by inhibiting mycolic acid synthesis, a key component of Mycobacterium tuberculosis cell wall. So without the mycolic acid, the bacteria can't maintain the structure, making INH bactericidal for active TB. Now, we do have resistance risk with TB, so INH must always be combined with other TB drugs when treating active infection. Okay, so isoniazid we are using for both active TB as part of RIPE therapy. So RIPE therapy you'll learn more about in actual infectious disease, but that is a standard first-line treatment, 6 to 9 months regimen for active tuberculosis, and it involves several drugs in combination. And then isoniazid can also be used for latent TB, typically for 6 to 9 months. The key adverse effects we have are peripheral neuropathy, especially in patients with vitamin B6 deficiency. So you want to sometimes co-administer vitamin B6 or screen for deficiency. Hepatotoxicity and hemolysis in G6PD deficiency. Rifampin, mechanism of action, this works by inhibiting DNA-dependent RNA polymerase, which blocks RNA synthesis, making it bactericidal. Rifampin is used for active TB, also post-exposure prophylactics for N. meningitis, and as adjunct therapy for leprosy. Adverse effects include there will be an orange discoloration of patient body fluids, hepatotoxicity, and GI upset. It is a strong CYP 450 inducer, so it can reduce the effectiveness of other drugs like oral contraceptives or warfarin. All right, ethambutol, mechanism of action, it inhibits arabinosol transferase, and this is an enzyme component of the mycobacterial cell wall. So this inhibition disrupts cell wall synthesis, making the bacteria more susceptible to immune attack and of course to other antibiotics, because we do use most of these TB medications in combination with others. So it is bacteriostatic, slowing the growth rather than killing it directly. This is one of those medications used in that RIPE therapy against active tuberculosis. I realized I forgot to put the uses on this slide. So the use would be active tuberculosis in combination with other therapies. And our adverse effects for ethambutol are optic neuritis, which is dose-related, can lead to red-green color blindness early, and then as it progresses, it can become blurred vision and actual visual acuity loss. You can also see rashes, joint pain, peripheral neuropathy. For this medication, you do want to do periodic visual acuity and color vision testing. Have caution in younger children and patients that may not reliably report the visual changes. Okay, so we're going to go over the treatment principles in TB, although I realize we have not done infectious disease yet. This is just an overview. So there's 2 ways that we have to treat TB: when it is active, so active evidence of disease, and when it is latent, that is a positive test but no clinical disease. So active TB requires a 4-drug regimen, which is RIPE, laid out here. The one we did not talk about was pyrazinamide because the exact mechanism of action is unknown, but just be aware it's part of that group of therapies used for active TB. So generally what happens is all 4 drugs are started initially, and then once drug susceptibility testing is available, one or more of these medications will fall off the treatment regimen. Usually this is a 6-month or longer treatment. Now for latent TB, this is again patients that test positive but do not have clinical disease. Especially important to treat these patients if they are immunocompromised, as they are most at risk for reactivation of the disease. Treatment options are INH alone, typically for 6 to 9 months, Rifampin alone for a shorter course, or INH and I always have trouble with this one, Rifampin for 12 weeks. And so the important thing to remember is you will see this a lot, latent TB, in healthcare because we are often exposed and then have positive testing without clinical disease. Okay, so our key monitoring for TB, LFTs or liver function test for INH and rifampin, both are hepatotoxic, especially when used together. Vision screening for ethambutol because of that risk of optic neuritis. So baseline visual acuity and color vision screening periodically. CBC for rifampin, rarely it can cause those hematologic side effects such as thrombocytopenia and leukopenia. And then in general, TB treatment generally has some type of adherence assessment. So for some patients, we have direct observation therapy, DOT, healthcare provider watches the patient take each dose. And the reason is this ensures compliance. So it is very critical to prevent treatment failure and even more resistance than we already have for TB and preventing the disease spread. Okay, so some of our drug interactions, rifampin is a strong CYP450 inducer. So induces cytochrome P450 enzymes, increasing the metabolism of many drugs, which decreases the efficacy of those drugs. There's a long list we will not go through. We've mentioned this in many other lectures. Isoniazid is a CYP inhibitor. So it inhibits certain CYP enzymes, which decreases drug metabolism, which increases drug levels and potential toxicity. And then alcohol is an additive for hepatotoxicity. So keeping in mind that INH and rifampin are hepatotoxic, combining with alcohol is of course going to increase our risk of liver injury. So contraindications, of course, severe liver disease for INH and rifampin. They are both hepatotoxic. And in general, we have to always check our LFTs prior to initiating therapy. Optic neuritis, I'll say it again for ethambutol. Have to avoid if the patient has pre-existing optic neuritis, but if we're prescribing it, check visual acuity and color testing. And then a new one, we did not talk about pyrazinamide, but gout patients, we do need to, pyrazinamide will decrease the renal excretion of uric acid, which can make patients more prone to gout. So just keeping that in mind for those active TB patients that we know are going to be on that 4-drug regimen. Okay, so how are we counseling our patients if we're starting TB medications? They have to take the drugs exactly as prescribed. So treatment, the regimen is multiple drugs, the ripe drugs taken together. This helps prevent resistance and ensure complete eradication of the Mycobacterium tuberculosis. So mixed doses or incomplete therapy can lead to treatment failure and drug resistance. For rifampin, patients should expect to have orange urine. This is harmless discoloration. It's not just urine, it can be sweat, tears, saliva, but you want to tell them it could actually stain like their contact lenses, for example. It is a reassurance, it is not dangerous. Patients have to avoid alcohol, especially INH and rifampin, as they are hepatotoxic, and that is going to increase the risk of liver disease. They need to completely avoid alcohol during treatment. And then they have to be counseled again to report any visual changes that would occur during treatment, and make sure to stress how important it is to adhere to the regimen. So TB therapy is often 6 to 9 months or longer. They have to be stressed to take the medications daily and on time. And then we do, again, sometimes use that directly observed therapies because TB resistance is becoming a major problem. Okay, moving on to antihelminthics. Okay, so our antihelminthics class, these target different types of helminths. So for example, roundworms. If patients get roundworms, they will get intestinal obstruction. Hookworms can cause iron deficiency anemia. Pinworms you will see commonly in children. These mostly cause perianal itching. Strongyloides, this can cause autoinfection and also disseminated systemic disease. And Onchocerca causes river blindness. So for the drug classes we have here is the bendazoles, so albendazole and mebendazole, and then we're going to touch again on ivermectin, which we talked about before. So helminths in general are eukaryotic parasites. So drugs must selectively target the worm-specific pathway, so either their energy metabolism, neuromuscular signaling, without harming the human host, similar to what we talked about with the eukaryotic fungal pathways. Okay, so our bendazoles, albendazole and mebendazole, mechanism of action, they bind beta tubulin, selectively disrupting parasite microtubules. So this leads to inhibiting the microtubule function. It impairs glucose uptake, depletes the parasite's glycogen stores, and leads to ultimately energy depletion and death. So this mechanism is selective for helminths due to the difference in the beta tubulin compared to humans. So clinically, we can use the bendazoles for pinworm, hookworm, ascariasis, which is another type of worm that can cause intestinal obstruction, and strongyloides. And then our adverse effects are GI upset, so nausea, diarrhea. If we have prolonged use, we have to monitor our liver enzymes, so LFTs, and these are contraindicated in pregnancy, teratogenic. Okay, so some examples of how we might use albendazole. Pinworm dosing you will see. So this is generally dosed as a 400 milligram single dose and repeated in 2 weeks, keeping in mind that this is one of those times where household members have to be treated. Hygiene is very important and reinfection is common. Hookworm is going to probably be treated by infectious disease, but for example, we could use this for 400 milligrams daily for 3 days, and that's going to treat the adult worms in the small intestines. And then neurocysticercosis, which is larva in the CNS, that for that we would use very high dose albendazole, and it's a longer duration, so 1 to 4 weeks, depending on if there are also cysts. And then we also typically are administering steroids with this medication because it's going to reduce the inflammation from the dying cysts that is going to occur when we kill off these helminthics. Okay, so we're revisiting ivermectin, reminding that the mechanism of action is binding that glutamate-gated chloride channels, and that increases the permeability to chloride ions, which causes paralysis and death of the parasite. For this, it is selective to the parasite because mammalian cells do not use the glutamate-gated chloride channels in the same way. So what can we treat? Strongyloides, this is the drug of choice. Onchocerciasis, which is a disease transmitted by the black fly, and they call it river blindness. It does require repeated dosing for years. We already talked previously about how we can use this for scabies as an alternative to topical permethrin. And then cutaneous larva migrans, which is caused by hookworm penetrating the skin, and ivermectin can be effective against that. So what are some of our adverse effects? Pruritus and rash. And this sometimes will be worse when treating the parasitic types rather than scabies, because it is from the rapid death of the parasites can make that rash and pruritus even worse. Mild hypotension, neurotoxicity is rare, but patients can get confusion and seizures. And then keeping in mind, this is useful in patients that cannot tolerate that topical treatment for scabies or have widespread infestations. So contraindications and precautions with this class. Pregnancy, remember, we want to avoid the bendazoles. It is category C, teratogenetic in animals, but human data limited, but why risk it? So the Mazzotti reaction, this is specific to treating onchocerciasis with ivermectin, and this is where patients will get fever, pruritus, lymphadenopathy, hypotension, and so not necessarily a allergic reaction, but rather an inflammatory immune response. So we may need to add corticosteroids to that treatment regimen. Liver disease, we have to be cautious with albendazole. And then in children less than 2 years, we're going to avoid our bendazole class unless absolutely necessary. Okay, so our counseling for antihelminthics, just as before, we have to treat the entire household for pinworm. So pinworm infections can spread very easily on surfaces, hands, linens. Everybody in the home generally has to be treated, even if they are asymptomatic. Reinfection can be very common. So hygiene measures, we need to frequent hand washing, trim fingernails, wash bedding, towels, undergarments. Many of these helminthic infections will need retreatment due to reinfection, persistent eggs in the environment. So a lot of times we will repeat the treatments after 2 weeks, and then making sure to tell patients to report the rash after ivermectin due to that Mazzotti reaction. And so we want to just make sure to be aware of that so we can provide the supportive care or the steroids if needed. Okay, moving on to vaccine pharmacology. So vaccines, I know we're all aware of what these are, but what is the purpose? So we want to stimulate adaptive immunity without causing disease in the patient. So adaptive immunity is the part of the immune system that learns and remembers specific threats like viruses or bacteria. It is slower to start, but gets stronger and faster with repeat exposure. So first we have an antigen presentation. So that is any foreign substance, so like virus, bacteria, or vaccine, that the body recognizes as a threat and builds an immune response against. And then we have the antigen presentation. So the process where immune cells show the antigen to other immune cells, like T cells, helping the body identify the invader. And then we have the activation of the B and T cells. For our B cells, white blood cells that make the antibodies, proteins that bind to antigens and help neutralize them. And then T cells are immune cells that are either going to kill these infected cells or help other immune cells. So those are our T helper cells. And then over time, we develop this immunologic memory. So after exposure, either through infection or vaccine, some B and some T cells remember the antigen. And if the body sees it again, the immune response is faster and stronger. So overall, a vaccine is a safe form of an antigen. It can either be dead, weakened, or synthetic, used to train the immune system without causing the illness. So your vaccine teaches your immune system to fight without needing to get sick first. So what are our different types of vaccines? So live attenuated, this type of vaccine contains a weakened version of a live virus or a bacteria that is still able to replicate but doesn't cause disease in healthy people. So the MMR and varicella are examples. One thing to keep in mind with live attenuated vaccines is that we would not use those in immunocompromised individuals or pregnant patients. Inactivated vaccines, this contains a killed version of the virus or bacteria. It cannot replicate, but still triggers that immune response. So influenza, intramuscular is an example. These are safe for immunocompromised patients. Subunit or conjugate vaccines, these only include pieces of the virus or bacteria, for example, the surface proteins that the immune system can recognize. So hepatitis B, HPV, pneumococcal, often these have fewer side effects. Toxoid vaccines are made from inactivated bacterial toxins, not the whole bacteria, just trains the body to fight the toxin, not the organism. So for example, tetanus and diphtheria. And then mRNA contains genetic instructions, which is the mRNA, teach your cells to make a harmless piece of the virus, like a spike protein to trigger immunity. So for example, COVID-19, the big thing to remember is it does not alter your DNA, but it is rather triggering immunity. So let's try to simplify the mechanism of how a vaccine works. So first, an antigen enters the body. So the vaccine introduces that harmless piece of pathogen, which is a virus or bacteria, into the body. Then we have APCs, which stand for antigen-presenting cells. These cells recognize the antigen, so these would be macrophages or dendritic cells, and they engulf the antigen and show it to the immune system, basically like putting up a wanted sign. This leads to T cell activation. So T cells are like the commanders in the immune system, and they get an alert to help and coordinate the rest of the response. Your B cells are stimulated. So these are the antibody factories, and they make the specific antibodies to that antigen to help neutralize it. And then over time, we get that memory cell formation. So some T and B cells will turn into memory cells, which will stay in the body. And this gives us that long-term protection. So the immune system remembers how to fight the real infection should it occur. Okay, so we're going to dive in a little deeper to live attenuated vaccines and also subunit vaccines. So live attenuated vaccines are vaccines made up from weakened or attenuated versions of live viruses or bacteria, keeping in mind they can still replicate, but generally do not cause disease in healthy people. So what is the mechanism here? They replicate at low levels in the body, and this triggers a strong immune response similar to a real infection without causing disease. So these are very effective, often give lifelong immunity after 1 to 2 doses. The contraindications is we have to avoid in pregnancy, and we have to avoid in severe immunosuppression, so chemotherapy, high dose steroids, or HIV. And so some examples of these are MMR, varicella, rotavirus, and intranasal influenza. Okay, so we're going to break down the inactivated and the subunit vaccines also. So inactivated vaccines are made from killed or inactivated viruses or bacteria. These cannot multiply in the body, so that makes them safe for pregnancy and immunocompromised patients. Classic example is IM influenza. And then our subunit or conjugated vaccine, these are made from specific pieces of virus or bacteria, so proteins, not the whole organism. These target a specific antigen, such as a viral protein. These are very safe, very few side effects. So examples of these are hepatitis B, HPV, HIV, and pneumococcal. And then your conjugate vaccines are generally protein and sugar. So why does that matter? So in general, infants do not respond well to sugar-only antigens. So attaching a protein improves the immune response in babies. So for example, your HIV vaccine, more effective in children when it is conjugate. So looking at the routes of administration for vaccines, most vaccines are going to be given intramuscularly. So flu, Tdap would be examples. These are injected into the muscle. Sub-Q would be used for MMR, varicella, so injected a little more superficially into the fat layer under the skin. And then oral medications, for example, rotavirus, can be swallowed as a liquid dose. Our adjuvants, so these are substances added to vaccines to boost the immune response. So some of the things you would hear about are aluminum salts are common adjuvants. When they have these adjuvants, you may see more vaccine site reactions, so swelling, redness, pain at the injection site, but in general, these are added to help produce that stronger, longer lasting immune reaction. So some of our common and normal local vaccine reactions: redness, swelling, and pain at the injection site, also mild fever. So what we do for these patients is reassure them this is not a systemic reaction, this is just a local reaction to the injection. So cool compress, NSAIDs or pain relievers, and then you want to make sure to counsel the patient. Again, this is not an allergic reaction and they are safe to continue with future vaccinations. So when are vaccines contraindicated? We don't give a vaccine if a patient has had a severe allergy to a vaccine ingredients, for example, neomycin or gelatin, anaphylaxis after a previous dose. So obviously severe life-threatening reactions, we would not repeat that, and they would need immediate treatment if they were having that reaction. Pregnancy for live vaccines, so MMR and varicella, those can cause fetal infection. And then our immunocompromised patients, again, the live vaccines because they have that weakened immune system. So vaccine counseling for patients. So we want to make sure to explain the expected reactions. So the low-grade fever, the soreness at the injection site, not a sign of illness, just a normal expected reaction. You want to clarify that vaccines do not actually cause the disease. Live vaccines are weakened and don't cause illness in healthy patients. And inactivated or subunit mRNA vaccines do not even contain live virus. You want to provide the vaccine information statement to the patient. So this is generally required by the CDC. It's patient-friendly, gives patients info on the risks and benefits. If the patient misses doses, you want to discuss that catch-up schedule. So many vaccines require a series, and so you want to make sure to complete the full dose to get full protection. And then there is usually a catch-up schedule if a patient misses a dose without restarting. And you want to explain that spacing and completing the full series is what gets us that strongest immune protection. Okay, so for vaccine documentation, we need to make sure to have the vaccine name. So for example, influenza, Fluzone, and the lot number. The reason we need the lot number is for tracking in case of recall or adverse events. You want to document the site, for example, left deltoid and the route given intramuscular or sub-Q, the manufacturer, and the expiration date. This ensures the vaccine is approved and not expired. The vaccine information statement. So again, this does need to be provided to the patient. Informed consent is noted. Document that you explain the risk and benefits and the patient agreed to it. Any adverse reactions need to be recorded clearly, and then follow-up timing if a patient is part of a series of vaccines indicate when they should return. So for example, administered influenza vaccine, 0.5 mLs IM in the left deltoid, lot number recorded, VIS dated, provided and reviewed, no contraindications, patient tolerated well, advised expected soreness, and return precautions.